Very good afternoon to all. This is Vasundhara Padma, clinical nutritionist from Apollo Hospitals, Visakhapatnam. Today, I am going to discuss with you about nutrition in critical care setups. Usually in critical care setups, we observe many disease conditions like pneumonia, dysglycemia, fluid overload, then dehydration, organ failures, stroke cases, anemia cases, and malnutrition cases, etc. So the treatment part, then coming to the treatment part, we cannot give same treatment to all cases. We try various treatment patterns to stabilize the condition. Like that, nutrition support also not same to all cases. We need to give utmost attention to treat the patients in critical care cases. So providing nutritional support in ICU is very, very important role. If you are not taken care at initial stage, definitely you won't get good achievement in later phases. Sorry, I have some technical issue. Slide mode. So in this topic, I am going to discuss with you about importance of nutrition, nutrition care process, the right feeding route, and about enteral nutrition, and about parenteral nutrition and disease specific nutrition. So then coming to the importance of nutrition. Nutrition, again, I'm going to emphasize about it plays very, very important role in patient recovery to prevent further metabolic deterioration and loss of lean body mass, and to prevent malnutrition, and to provide nutritional support in critically ill cases. And you can see improvement in patient outcomes, and you can see decrease in morbidity and mortality rate, and you can see decrease in the length of hospital stay and also hospital cost. So now I am going to discuss about nutritional care process. The nutritional care process means it is a systematic approach to provide high quality of nutrition care. Here, this nutritional care process can be given in 4 steps. Those are nutrition assessment, nutrition diagnosis, nutrition intervention, and nutrition monitoring and evaluation. Then coming to the nutritional assessment part. Here, this nutritional assessment, again, it is a systematic approach and process of collecting and interpreting information like anthropometry, biochemical data, and signs and symptoms, and diet history in order to um, make decisions. So for that, we use 2 things. One is nutrition screening tool and one is nutritional assessment tool. These tools are globally approved tools which are practicing in hospitals. The first one is the Nutric score. It is highly uh, uh, important tool to assess the nutrition screening. Then second one is nutritional risk screening tool, that is NRS 2002, and geriatric nutrition risk index, nutrition risk index, and MUST, malnutritional universal screening tool. And then coming to the assessment part, subjective global assessment and mini nutritional assessment tools are globally approved tools. So for bedridden cases or critically ill patients, we get difficulty in assessing the BMI. There, we can't take physical measurements for height and weight. There, we need to follow some techniques or tips. Here, this is one technique you can follow to take height, that is demispan. Here, the measurement uh, uh, will be like from the middle of the sternum knot to the middle finger, preferably left arm, left arm, left arm. Height in centimeters, you get the distance of demispan. If person is female, just calculate like this: 1.35 into demispan length plus 60.1. If patient is male, apply this formula: 1.4 into demispan plus 57.8. This is another method to calculate rough height. In few cases, it is difficult to take demispan length. In few cases, the hands may be with a lot of infusions, drips and all. So for those cases, knee height will be ideal. Here the knee height can be measured from anterior surface of thigh to heel of the foot, under the heel of the foot. The distance you need to measure, then apply in this formula. For female, 84.88 minus 0.24 into A's plus 1.83 into knee height. For male, 64.19 minus 0.04 into A's plus 2.02 into knee height. So after getting that ideal height, you can apply this ideal body, you can apply in this formula, that is ideal body weight. This is also known as a Hamby equation method. For example, if patient is female and having 5 feet 2 inches, so your calculation should be for 5 feet, just take 45 kgs, and for 2 inches, add 2.3 into 2. So like that in males, just for 5 feet, take 48 kgs, and for each inch you have to add 2.7. And after getting that value, then assess frame size. If he is a small frame, subtract 10%, and if he is large frame, add 10%. So ideal body weight is useful for few cases, and usual body weight is another method. Usually we assess nutritional requirements for elderly people by applying this usual body weight method. And adjusted body weight is one more method. Here for obese cases, usually we apply this method. So adjusted body weight is equal to actual body weight minus ideal body weight into 0.5 plus ideal body weight. So this is about nutrition risk screening. Usually in nutrition risk screening, table 1 and table 2 will be there. Table 1 is initial screening and table 2 is the final screening. Here in table 1, first you should know about BMI. Is BMI is less than 20.5, or you have to know, has the patient lost weight within last 3 months, or has the patient had a reduced dietary intake in the last week. Is the patient severely ill? If in above 4, at least one is S, you have to do final screening. If it is no to all 4 questions, no need to do this table 2. This final screening method, if you get more than one S, you have to apply this table. Here, first, impaired nutritional status. Patient is having normal nutritional status and patient is having major abdominal surgery. So you have to take score only 2. If patient is having weight loss of more than 5% in 3 months and patient came with head injury, you have to take for weight loss less than 5% 1 plus head injury 3. So the score will be like 4. So based on the score, you have to do risk assessment. Here, if score is more than 3, the patient is nutritionally at risk and the nutrition care plan should be initiated. If score is less than 3, weekly rescreening of the patient should be done. If the patient is scheduled for any major operation or a preventive nutritional care plan, you have to monitor regularly. And this is about Nutric score. Here we have some variables like age, Apache, SOFA, number of comorbidities, days from hospital to ICU, and interleukin 6, IL-6. So here age you have to consider and you have to set score. And Apache. Apache means it is the most widely used ICU mortality prediction score. That Apache means acute physiology and chronic health evaluation. By evaluating the patient condition, you have to give scores here. And SOFA means sequential organ failure assessment score. In Apache, you have to evaluate age-wise, GCS-wise, temperature, heart rate, respiratory rate, arterial pH, sodium and potassium, creat value, acute kidney injury, hematocrit and WBC, etc. In SOFA score, you have to evaluate FiO2, then mechanical ventilation or not, and platelets, bilirubin value, GCS, creatinine and urine output, etc. So by evaluating all these things, you get some score. So based on that score, you have to assess the category. Like if that score is between 6 to 10, you have to give high score. If it is 0 to 5, it is low score. If IL-6 is available, you have to apply above table. And if IL-6 is not available, you have to apply this below table. If it is okay, this is about guidelines. Guidelines for provision and assessment of nutritional support therapy in adult critically ill patients, conducted by Society of Critical Care Medicine and American Society of Parenteral and Enteral Nutrition. Here, they have recommended that patients at risk are defined by an NRS 2002 more than 3 and those at high risk with a score of more than 5 or a Nutrix score more than 5 if interleukin 6 is not included, otherwise more than 6. IL-6 is rarely available as a component for the Nutrix score. Therefore, Haaland et al. Have shown that Nutrix score more than 5 still indicates high nutrition risk. Then coming to the step 2 in nutrition care process, that is nutrition diagnosis. Here we apply this PES statement. PES means problem, etiology, and signs and symptoms. First, you have to do nutritional focused examination and you have to identify the nutritional problems. Then you have to analysis, root cause analysis should be done. Then based on the signs and symptoms, you have to start intervention. Here this is step 3 in nutrition care process. First you need to calculate nutrient requirement of the patient and you should decide the feeding route and you should plan the disease specific diets. So for nutrition intervention you have to apply this table. Here this is ASPEN 2016 Critical Care Nutrition Guidelines. In that, nutritional requirements are given like this. If BMI is less than 15, the energy requirements should be 34 to 40 kilocalorie per kg ideal body weight. If patient BMI is 15 to 19, the energy requirements must be 30 to 35 kilocalorie per kg ideal body weight. If patient BMI is 20 to 29, the calorie requirements must be 20 to 25 kilocalorie per kg body weight. If patient is more than 30 BMI, the calorie requirements must be 15 to 20 kilocalories. In case of obese, if the BMI is 30 to 50, the calorie requirements must be 11 to 14 kilocalorie per kg actual body weight. And if patient more than 50 BMI, 20 to 25 kilocalorie per kg, ideal body weight per day. And this is about protein requirement. If patient is normal, give only 0.75 grams per kg ideal body weight per day. And if patient is with metabolic stress or sepsis or post-operative care, give 1.2 to 1.75 grams per kg ideal body weight. If in case of burns or large wounds or severe trauma, the protein requirements must be 1.5 to 2.5 grams per kg ideal body weight. If patient is on hemodialysis, the protein requirements varies from 1 to 1.4 based on the condition. And if patient is peritoneal dialysis, the protein varies from 1.3 to 1.5 grams per kg ideal body weight. And patients who are on CRT, continuous renal replacement therapy, the protein requirements must be 2 to 2.5. In case of obese, the protein requirements like for BMI for 30 to 40, 2 grams per kg ideal body weight. If BMI is more than 40, you can give up to 2.5 grams per kg ideal body weight per day. So here you should know, if severely malnourished as per NICE guidelines, use actual body weight for energy and protein recommendation initially for a week, then gradually set up to reach the goals of ideal body weight after stabilization. And this is for step 4. You have, after assessing the case, after setting the targets like protein and energy, you have to monitor nutritionally and evaluate. For that, first monitor the intake and tolerance of the patient and monitoring the changes in physical biochemical parameters and doing necessary changes in the diet if needed. By doing all these things in a systematic way, you can easily overcome the dilemmas. Usually in ICU care setups, we have these dilemmas: why to feed, what route should be preferred, which patient to be offered nutritional support, how much to feed, what is the ideal composition of the feed, when to start, all these things. So if you have done proper nutritional care process, easily you can set targets. So this is about the right feeding route. First, oral nutrition should be given who can swallow safely and GI tract is functional. And enteral nutrition should be given who fail to respond with oral nutrition alone. GI tract is functional, adequate motility and absorptive capacity, and parenteral nutrition. When enteral is not feasible for 7 days, gut is not fully functional, gut physically inaccessible, tube feeding is unsafe or unlikely to be effective. Then this is about the adequate nutritional status. If patient is having adequate nutrition, just start oral diet, reassess nutritional status regularly, simple IV to maintain the hydration if necessary. And if he is not nutritionally in good status, nutrition support should be started. Select an appropriate feeding route. And if patient functional GI tract, appetite satisfactorily and physically able to eat, oral diet and supplement as necessary. If appetite is satisfactory and physically not able to eat, enteral nutrition by feeding route should be initiated. And if function GI tract is not good, only short-term support anticipated and not severely malnourished, parenteral nutrition by peripheral vein can be started. And if patient is not appropriate for this, parenteral nutrition in central vein should be started. And this is about enteral nutrition. Usually these are the routes we give feeds enterally. In that, nasoenteric feeds, enterostomy tube feedings. In nasoenteric feeding tubes, nasogastric tube feeding is there, nasoduodenal or nasojejunal tube feeding. In enterostomy tube feedings, percutaneous endoscopic gastrostomy, PEG, percutaneous endoscopic duodenostomy or jejunostomy, PEJ or PED, open surgical needle catheter and laparoscopic gynostomy, surgical enterostomy, and surgical gastrostomy or gynostomies are available. So after selecting the route, you have to select the formula. By seeing the digestion and absorption of the patient, if gut is functional, go with standard formulas. And in some cases, require fiber modification. In some cases, you have to opt low fiber diet, and in some cases, you have to opt high fiber supplements. And if patient digestion and absorption is impaired, go to enteral formula feeds, elemental formula feeds. Then calculate the nutritional needs and determine individual tolerance. And moderate nutrient, if patient is having moderate nutrient needs, go with the standard or blend-raised formulas with moderate fiber content. And patient require high energy and high proteins, high calorie, high protein formulas or high protein formulas, immune support or wound healing formulas are preferable. And glucose intolerance to standard formula, carbohydrate modified formulas for glucose intolerance, and fluid restriction cases, high calorie, low sodium formulas that meet other nutrient needs in restricted volumes. And fluid electrolyte and protein restrictions, renal insufficiency formulas or hepatic insufficiency formulas are preferable. And while starting any enteral formula, these factors should be considered in that patient related factors. You have to check the medical situation. You have to know medical history and management, surgery, especially related to GI tract, nutritional status assessment, presence of malnutrition, food allergies, period of nil per mouth, and management of complications like disease specific requirements, biochemical abnormalities, GIT malabsorption, diarrhea, or constipation, and nutritional prescription, access route, naso, oral, or gastric versus small bowel access, nutritional requirements, total energy and macronutrient distribution, fiber needs, micronutrient needs, total fluid requirements should be considered. And implementation of feed, administration method, continuous over 24 hours versus cyclic over 18 hours, and availability of feeding pumps, and logistical matters, available resources, budget, tender specifications, available staff, mixing facilities. All these things must be considered while selecting the appropriate enteral formula. And timing of nutrition in critically ill cases. Chew feeding to be considered if even 50 to 60% of nutrition target are not met adequately within 72 hours of oral nutrition support. Enteral should be started very early, preferably within first 24 to 48 hours. In case the nutrition requirement is not met adequate with enteral nutrition, even after 7 days of ICU admission, then try to use the parenteral nutrition. 3 previous meta-analysis aggregated data from randomized control trials comparing early versus delayed enteral nutrition. In one meta-analysis of 8 trials by Haaland et al. Showed a trend towards reduced when enteral was started within 48 hours compared with the delayed initiation of enteral nutrition started after that point. A second meta-analysis of 12 trials by Marek et al. Showed significant reduction in infectious morbidity and hospital length of stay when early enteral nutrition was started on average within 36 hours of ICU admission. A third meta-analysis of 6 trials by Doing et al. Showed a significant reduction in pneumonia and mortality, but massive difference in multi-organ failure when early was started within 24 hours of admission to the and compared to the enteral started after that point. So these are the things you have to monitor while giving enteral nutrition. These are the parameters. First, nutritional parameters should be monitored frequently. In that, nutritional and fluid administration should be checked daily. Fluid balance should be checked daily. Weight, BMI, etc. should be checked weekly and bi-weekly. And laboratory parameters like sodium, potassium, glucose should be checked initially, daily, and phosphorus, calcium, urea, creat, ALT blood count initially twice or weekly. Albumin, prealbumin should be checked weekly or every second week. And functional status, hand grip strength should be checked daily. And tube and enteral related things like nausea or vomiting should be monitored daily, diarrhea should be daily, constipation should be checked daily or twice weekly, tube conditions and fixation should be checked daily, and stoma site should be checked daily. And clinical conditions like general conditions should be checked or assessed daily, and drug therapy should be checked daily. So if you check all those things and if you start early enteral nutrition, these are the benefits usually you get to your patient. That is, those are maintains gut integrity and preserve lean body mass, attenuate disease severity, and modulate stress and the systemic immune response, and reduce the risk for systemic infections, and lessen likelihood of multiple organ dysfunction syndrome. And when should enteral nutrition should be delayed? If shock is uncontrolled and hemodynamic and tissue perfusion goals are not reached, in case of uncontrolled life-threatening hypoxemia, hypercapnia, or acidosis, in patients suffering from active upper GA bleed, in patients with overt bowel ischemia, high output intestinal fistula, if reliable feeding access distal to the fistula is not achievable, abdominal compartment syndrome, and if gastric aspirate volume is above 500 ml in 6 hours. So this is about complications of enteral feeds. Usually we observe these complications while giving enteral nutrition. First one is the diarrhea plus or minus nausea and vomiting, dehydration and infection. Here possible causes are medications, or lack of dietary fiber, or hyperosmolar formula, bacterial contamination, improper administration, and fat malabsorption. And in sometimes we observe this symptom like constipation. It may be because of inadequate fluid intake or insufficient fiber intake or GA obstruction. And aspiration of the tube feeding or high gastric residual volume, more than 250 in 2 or 500 ml in 1. Regurgitation of stomach contents or feeding while supine or delayed gastric emptying or tube dislodgements or GERD. And hypoglycemia. Sudden cessation of the tube feeding in patients in oral hypoglycemic drugs or insulin. And hyperglycemia, diabetes, stress, trauma, corticosteroids, sepsis, and refeeding syndrome. Hypophosphatemia or hypokalemia. It may be because of refeeding syndrome or excessive losses. Others due to technique itself or after tube insertion, GERD, aspiration, wound infection, etc. So this is about refeeding. Refeeding is usually we observe in ICU care patients who are with malnourished. So these are the things you have to monitor and you should overcome from these conditions like hypokalemia, hypomagnesemia, hypophosphatemia, thiamine deficiency, salt and water retention, etc. So feed should be started initially with a very low rate. Then if patient is tolerating, you have to, you should try to achieve the target. So this is the enteral nutrition practice policy. Many hospitals are following this policy. That is, nutrition screening is done and diet prescribed by the consultant. Nutrition assessment and nutrition care plan is done by the dietitian and updated thereafter every day. The product is prescribed by the dietitian. The product is indented by the nurse and sent to the liquid section. The tube feed is prepared under laminar air hood and served at bedside. The feed is transferred into the feeding bag by the nurse who sets the rate of flow. And continuous feeding is mandatory everywhere. And coming to the parenteral nutrition, what is parenteral nutrition? It is the intravenous administration of nutrition, which may include protein, carb, fat, mineral and electrolytes, vitamins and other trace elements for patients who cannot eat or absorb enough food through tube feeding formula or by mouth to maintain good nutritional status. Who receives parenteral nutrition? In patients whose nutrient requirement is not met through oral or enteral nutrition, parenteral nutrition can be started. People of all ages receive parenteral nutrition. It may be given to infants, children as well as to adults. Indications to start TPN. Usually the TPN can be started to chronic intestinal obstructions as in intestinal cancer, bowel pseudo-obstruction with food intolerance. TPN can also be used to rest the bowel in case of GA fish loss with high flow. When an infant's gastrointestinal system is immature or has a congenital gastrointestinal malformations, when there is a post-operative bowel anastomosis leak, when the patient is unable to maintain nutritional status due to severe diarrhea or vomiting, small bowel obstruction, hypercatabolic stress, an anticipated period of nothing by mouth status grad. So, parenteral nutrition guidelines. Should we use central venous access for parenteral nutrition administration? The statement is a central venous access device is often required to administer the high osmolarity parenteral nutrition mixture designed to cover the nutritional needs fully. Peripheral venous access devices may be considered for low osmolarity. How much parenteral nutrition should be given to critically ill patients? Recommendation. During acute illness, the aim should be to provide energy as close as possible to the measured energy expenditure in order to decrease the negative energy balance. Is there an indication for parenteral nutrition supplementary to enteral nutrition? The recommendation is all patients receiving less than their targeted enteral feeding after 2 days should be considered for supplementary parenteral nutrition. Carbohydrates, what are the requirements? The recommendation is the minimal amount of carbohydrate required is about 2 grams per kg of glucose per day. How much should be administered to meet protein requirement? The recommendation is when patient is indicated, a balanced amino acid mixture should be infused at approximately 1.3 to 1.5 grams per kg ideal body weight per day in conjunction with an adequate energy supply. This is about parenteral nutrition practice policy. The consultant decides the initiation of TPN and the referral to the dietitian. Nutrition assessment and nutrition care plan is done and updated thereafter every day. The product is suggested by the dietitian. Nurse indents the products, initiates and monitors the rate flow. Use of 3-chamber bag is mandatory. And this is about disease specific nutrition. Um, these are the recommendations we need to follow while planning of acute kidney injury patients. The recommendations are standard enteral formula is recommended for ICU patients with AKI. It is strong recommendation and protein should not be restricted in patients with renal insufficiency and daily protein intake should be in the range of 1.2 to 1.7 grams actual body weight in AKI patients. In case of significant electrolyte imbalance, especially formulation designed for renal failure should be considered. And this is about respiratory compromised patients. Small and frequent feeds should be preferred to improve nutritional compliance. Especially high-fat, low-carb formulas is not recommended for ICU cases with ARF. Calorie-dense enteral formulas should be recommended for patients with ARF, especially if in state of volume overload. There is no additional advantage of these disease-specific low-carbohydrate and high-fat over standard or high-protein or high-energy oral nutrition supplement in stable COPD cases. This is about traumatic brain injury recommendations. Initiation of early enteral nutrition after post-trauma period within 24 to 48 hours of injury. Once the patient is hemodynamically stable is recommended. And protein recommendation should be in the range of 1.5 to 2.5 grams per kg per day. And arginine containing immune modulating formulas are ecosa pantothenic acid or ecosa hexagonic acid supplements with standard enteral formulas in traumatic brain injury patients is recommended. And this is about hepatic failure cases recommendations. Enteral nutrition should be preferred in patients with acute and chronic liver disease admitted to intensive care unit and tailor sodium restriction to absolute needs. A whole protein formula providing 35 to 40 kilocalorie per kg body weight per day energy intake and 1.2 to 1.5 grams kg body weight per day protein is recommended. And no beneficial of branched chain amino acid formulations in critically ill patients with encephalopathy who are receiving first line luminal antibiotics. And protein restriction should be avoided in refractory encephalopathy. And protein supplementation is recommended in liver failure. Protein energy determination should be based on dry body weight or usual body weight instead of actual body weight. These are the strong recommendations for hepatic failure. And thank you. Thank you for patient listening. Now I am ready to take questions.